Hello, my name is Kristen Calloway, and this talk is focused on evaluation and management of airway stenosis in children. We will talk about airway stenosis in general and provide a framework in which to think about them. For this to happen, it's critical to think about the entire patient, including comorbidities, especially pulmonary and ventilation status. We will discuss various options for management and think about how to arrive at the best option. All this is to provide tools with which surgeons can better work. In thinking about airway obstruction, perhaps the most critical piece of information is at which level the obstruction is present. For otolaryngologists, this is typically separated into supraglottic, glottic, subglottic, and tracheal. In Dr. Hartnick's presentation, he focused on subglottic stenosis, and we should have a good idea of this classification scheme now. As he pointed out, the proximity to the vocal cords is key in assessing the condition and creating a surgical plan. In subglottic stenosis, the narrowing and scar is just below the vocal folds, and it's too close to resect or cut out. So, as he explained, anterior or posterior, or both, grafts need to be placed to expand this area. We're going to talk about how to make a decision about how to do this. So there are conservative options for airway stenosis that are not the focus of this talk. This would be observation with tracheostomy or endoscopic interventions or balloon dilation. We will discuss options for surgical reconstruction based on the level at which the narrowing happens. So as you can see, for subglottic narrowing, we can opt for a LTR or a CTR or a posterior cricoid split. At the level of the trachea, tracheal resection and slide tracheoplasty are options. Suprastomal collapse and tracheal malacia, external stenting is an option, which we will not touch on, but that will be a focus of a later talk. So contraindications for airway reconstruction include severe tracheal malacia, uncontrolled reflux, reactive airway disease, active eosinophilic esophagitis, and also tracheostomy tube dependence due to a chronic pulmonary disease or neurologic impairment, including oxygen dependence. So if they're dependent on their trach tube, there's no point in trying to take it out. In the area of the subglottis, we'll go over the type of LTR to pursue, so whether or not to think about anterior or posterior grafting, what stage of LTR, what that means, what a single, a double, and a 1.5 stage is, to consider type of graft, type of stent, and duration of stenting will also be topics that we'll touch on. So here there are various examples of subglottic stenosis. The top left stenosis, you can see that there is collapse from the anterior and posterior dimensions. So that might benefit from anterior grafting alone. However, if a posterior graft was needed in order to expand the airway to an age-appropriate size, the posterior cricoid region does not look so scarred that it would not accommodate that. The oval shape of the top right stenosis and the bottom left stenosis shown here would likely require both anterior and posterior grafting. The bottom right stenosis is a grade 3, almost grade 4, and would also require both anterior and posterior grafting. So, in a single stage procedure, there's no tracheostomy, as you can see in this top image here. A nasotracheal tube is used as a form of a stent to hold the grafts in place. The green is the anterior graft and the red is the posterior graft. This is necessary from anywhere from 3 days to 1 week, depending on whether an anterior graft, a posterior graft, or both grafts are used. In a double stage procedure, shown at the bottom, the patient is awoken at the end of the procedure. A suprastomal stent is placed above the tracheostomy. This stent can be made from various materials, and it's commonly made from a modified T-tube. However, there's a disadvantage of the double stage in that sometimes granulation tissue can form just above the tracheostomy due to rubbing of that stent. So therefore, a 1.5 stage LTR procedure may be beneficial in that case. So this allows a tracheostomy to stay in place as a safe backup airway while the patient is nasotracheally intubated. So the big question is, when do you use each of these options? In general, single-stage procedures are performed in older children with a clear subglottic stenosis who do not have any pulmonary pathology. A patient who only needs one graft is also an excellent candidate for this approach. Children who require a double-stage procedure often cannot tolerate sedation or time on a ventilator. They have pulmonary disease that would put them at risk for pneumonia or other respiratory complications if they were to be placed on a ventilator electively. Children who are candidates for 1.5 stage procedures require multiple grafts. Although they have good lungs, they may have an existing tracheostomy. However, this approach can be taken in a child without an existing trach as well by creating a new stoma at the time of surgery. Moving on to cricotracheal resection. So CTR is a useful surgery for a child who has severe stenosis, such that the anatomy of the glottis is respected. So as you can see here, it's indicated for grade 3 or 4 stenosis, and preferably there's a margin of at least 3 to 4 millimeters from the vocal cords. So we like to respect these vocal cords, as this is the goal of the surgery, is to preserve phonation. So the procedure itself goes a little like this. So this image depicts the ultimate cuts of the CTR. So first, the airway is opened and the stenosis is assessed. If it's appropriate to proceed, the cricoid is removed as shown in this picture, and it's removed in a piecemeal fashion. The posterior cricoid mucosa is infiltrated with an anesthetic. It's then elevated off the posterior cricoid cartilage. The posterior cricoid plate is drilled down to be flat, and the cuts for the CTR are completed superiorly. The tracheal rings are released from the surrounding tissue, taking care to respect the muscular layers of the esophagus. The tracheal rings involved in the stenosis are removed. Inferiorly, at least 2 viable rings are left between the distal tracheal stump and the tracheal stoma. If not, it's necessary to include the stoma in the incision. Here we can see that the posterior sutures are placed first, followed by the anterior sutures. Here you can see that the superior anastomosis is created by suturing the mucosa to the posterior cricoid mucosa to the remainder of the posterior cricoid cartilage. Some of that mucosa is tracheal mucosa that has been separated from the tracheal rings that were resected. And this is an inferiorly based mucosal flap. There are multiple ways to do this, including by raising a superiorly based mucosal flap. However, this is the recommended approach. The superior anastomosis, by sliding this up, allows resection within 1 millimeter of the vocal folds for this procedure. So if you have a superiorly based flap, you can't get this close. These are post-operative photos from a child who had a cricotracheal resection. Moving lower onto tracheal stenoses, you can see that there are various degrees of tracheal stenosis that you can deal with, and the degree of tracheal stenosis depends will dictate what type of procedure you need to do in order to expand it. So on bronchoscopy here you can see a view of vocal folds, and underneath is a severe tracheal stenosis. There is a good amount of distance between the glottis and the stenosis, and it can be anywhere along the trachea. So this shows concentric tracheal stenosis. Critical things that you want to ask yourself is how thick the stenosis is, meaning is it just a mucosal stenosis, or does it have scar to it, or does it even have cartilage involved in it? How long is the stenosis, and how would you approach it? A great way to assess the length of the stenosis is through imaging, through a CT scan or an MRI. So you need to know the level of the stenosis, the length, and therefore both a bronchoscopy and imaging will be helpful. So there are 3 types of obstruction: short segment stenosis, funnel-like long segment stenosis, and generalized long segment stenosis. In evaluating the patient, operative bronchoscopy is performed with various telescopes, and it's very critical to have the patient spontaneously breathing during this time. You can also be prepared for the event of an airway emergency, and I'll show you on the next slide how. So you need to have spoken to the patient, or the patient and the parents possibly, about need for tracheostomy, for sternal trach, or for ECMO. It's also helpful to have imaging beforehand. This is an example of an elongated endotracheal tube, where a 3.0 endotracheal tube or a 2.5 narrow endotracheal tube is sutured to the end of a larger, longer endotracheal tube, such that for an older child or for adults, you can access the narrowing because these smaller endotracheal tubes do not have the length to get there. In congenital tracheal stenosis, there are a couple different options. So observation is always an option, dilation or stenting. As we sort of touched on earlier, this would be conservative management. Resection with end-to-end anastomosis or slide tracheoplasty is what we'll be talking about here. So tracheal resection and reanastomosis, the general principles is that there is a segment of stenosis that you cut out and then you reanastomose the distal segment to the proximal segment using sutures. In order to do this, you have to have enough mobility of the inferior segment to pull it up. If you do not have the allowable mobility of the inferior segment due to the length of the stenosis, a slide tracheoplasty could be indicated. This is usually for long segment tracheal stenosis. So a slide tracheoplasty is performed by performing an anterior incision of the trachea distally and a posterior incision of the trachea more proximally. So as you can see, these segments are split open. The distal segment is mobilized, and the two segments are lined up such that they can be sutured and anastomosed closed to create a larger airway. A slide tracheoplasty has to be done under ECMO. And this is an example of a postoperative result after a slide tracheoplasty. So this concludes our first teaching video. I hope you found it useful.